Wonderful. Good morning, good afternoon, good evening. I'm delighted to welcome you to this first Gender and Health webinar on what works, convened by UNU-IIGH. I'm Asha George. I'm a professor at the School of Public Health at the University of the Western Cape. And I will just introduce myself, the Institute, and the series as participants are joining. So UNU, the United Nations University, has an International Institute for Global Health. It's based in Kuala Lumpur, Malaysia. Several of you will have engaged with UNU and the exciting team at IIGH. It's the designated UN think tank on global health. The Institute serves as a policy translation hub for UN member states, agencies, and programs. It generates policy relevant analysis by applying a gender lens to inform the development, implementation, and evaluation of health programs. It also seeks to support the capacity and development of local decision makers and stakeholders to engage effectively with global health challenges within the 2020 Agenda for Sustainable Development. I'm very excited to be working with them in this Gender and Health Hub. They've received funding to set up a Gender and Health Hub, and one of the activities they will be doing is a webinar series. And this is the first webinar series, kicking off that series. It's coordinated, the Gender and Health Hub is coordinated by UNU-IIGH. It's a platform for collaboration, practice-based learning, and co-production of critical analysis and evidence on promoting gender equality in health. In addition, the Gender Health Hub strives to broker new partnerships and alliances to extend the sources of evidence and support dissemination and policy translation. It seeks to host timely debates on how to address gender in health. The series aims to engage a broad range of stakeholders, practitioners, policymakers, academics, and civil society to examine the evidence and build the political will to really translate that evidence into policy and action on the ground. So today's session, we have over 75 people registered, and I can see it's exciting to see an initial 35 have joined. Many more will be joining us as we get started. It's for an hour. It will be in a webinar format. And that means at the moment, we will only have one-way audio and camera. We will first hear from our panelists, who will speak for 5 minutes each, and that will be followed by a panel discussion. We're going to have a conversation between these two leading experts coming from two different fields, but sharing commonalities and lessons on what works to advance gender equality in health. And then we will be following up with a Q&A session. So you will have, you will see at the bottom of your screen, there is a Q&A button. Please send in your questions because we will be looking at those questions and allocate time to answer them. And then we'll close out with a multimedia piece linked to this initiative. So let me introduce the speakers. We're delighted to have speakers who are leading contributors in their field. Professor Lorenzo, who you can see is dialing in from the Philippines. Professor Lorenzo is the current chair of the Commission on Higher Education, the Technical Committee of the Nursing Education of the Philippines, the Committee of Nursing Education. She's been a member of this commission since the early 2000s, spearheading the quest to ensure the quality of Philippine nursing education. She was also the project director of USAID's HR 2030, and that was the leading initiative funded by USAID to address human resource development and management. It was designed to assist the Department of Health in health systems reform focused on HRH and the country's pursuit for UHC. She's a professor at the retired professor at the Department of Health Policy and Administration at the College of Public Health at the University of Philippines, and she has championed teaching and conduct of research on health policy studies and policy analysis. She's the founding director of the National Institutes of Health Policy and Development Studies, and she contributes in many ways to health policy debates in Philippines on a broad range of topics, including climate change. We're delighted to have her here. She has an MPH, BSN originally, but also has earned her DRPH from the University of California at Berkeley. She's been an active member in the Philippines community, and we're delighted to have her extensive experience and as with evidence, but also as a champion for advancing human resources for health and health policy reform in the Philippines more broadly. Delighted to have you with us, Professor Lorenzo. She will be in conversation with Dr. Avni Amin. Dr. Amin works at the WHO's Department of Reproductive Health and Research on violence against women. She's been a long-time expert in gender and health. Her primary focus is to support countries' ministries of health in the translation and uptake of WHO's normative guidelines and tools to strengthen health systems' responses to violence against women. She's led the development of clinical guidelines for responding to child and adolescent sexual abuse, and is the lead author of the WHO Global Plan of Action on Strengthening Health Systems' Response to Addressing Interpersonal Violence, in particular, violence against women and girls and against children. She's a passionate, many of you who know her know she's a passionate feminist scientist with a fierce commitment to gender equality and women's health. She has a PhD in international health from Johns Hopkins School of Public Health, and we're delighted. She's been in Geneva for many years, championing the advancement of gender equality in global health, and but has worked extensively around the globe in her role at WHO Geneva. So we're delighted to have both of you here to kickstart this webinar series and to share lessons. What has worked, what have been some of the key challenges, but what has also worked in each field? And is there a way we can share lessons across each field to advance gender equality in health? There's been a huge, to set the scene, there's been substantial work on gender-based violence, and yet there's so much to do. And I think COVID-19 has highlighted that. It's put the whole lockdown experience, the loss of livelihoods, and what the implications of that on gender-based violence have been tremendous. COVID-19 has also put health workers on the front line, and they have been the heroes behind COVID-19 responding to the pandemic. And what is striking is that they have, while responding to the pandemic, also been experiencing many of the stresses of society. So not only responding to gender-based violence, but also experiencing violence themselves. And what is striking in the BMJ series that UNU-IIGH led with WHO that was launched to celebrate Beijing 25, we had a piece that really looked at violence against women health workers and did an analysis of what underpins that. So this is a terrific webinar to bring two leading experts in conversation to bring insights from each of their fields. So let me hand over first to Professor Lorenzo. She has a brief presentation to set the scene, reflecting her experience in Philippines and her perspective on key insights from the field of human resources for health. Thank you so much, Professor Lorenzo.
Okay. Good afternoon, good evening, good morning. I'm waiting for screen sharing for me to be allowed to screen share. Okay, great. Okay, so good morning, good evening, good afternoon to all of you. And thank you for having me in this webinar. That's a very exciting way of beginning this discussion and and conversation on gender equity and health. I called this presentation entitled it Protecting the Health Workforce, incorporating gender equity provisions in HRH systems and management. Especially in these COVID times, we have really seen a lot of changes, and it looks like our health service delivery systems, as well as our health human resource development systems, have not really kept up. So very quickly, we'll just engage in a discussion, current situation of gender equity in human resource for health systems and health systems as well. So, so far, most work on gender and healthcare is focused on some issues, including a wide range of barriers to institutional access experienced by women users. So the focus on demand issues, we think is good, but it should not stop there. Another issue is gender discrimination in healthcare expenditures of accessed by women and girls, and you can see that. There's also a lot of concentration on reproductive health only when it comes to discussions on gender equity, to the neglect of other dimensions of people's health, and the impact of cost recovery programs on women and girls. We feel that the discussion and the study, especially the research, should actually be expanded. There's very little emphasis on gender in relation to the production of healthcare. But if we were to look at healthcare delivery, there is a very clear gender dimension to both formal and informal care systems. We all know that with the focus of the world in universal health care, there is a lot of attention right now to ensuring that primary care is of high quality, and that access to primary care would then help people gain access to the whole health system with all the services available to them. The gender dimensions can be seen on both sides. First, much of the non-institutional healthcare, as we know, is carried out by females. The mothers, the sisters in families usually are the ones that take care of access to health, and also are the ones that provide healthcare within their families. Similarly, we see that informal healthcare systems, starting from the village units, healthcare units, to district hospitals and to tertiary hospitals, there are a lot of gender differentiated divisions of labor and associated hierarchies. In the hospital setting, especially, a lot of them employ women predominantly as nurses and midwives. While in some countries, like in the Philippines, the gender parity in terms of many female doctors already going in service, even in tertiary care hospitals, and men going into nursing is now acceptable. But in many other settings, we see that women frequently are in specific segments of the health labor force, and most of them are in the lower hierarchies in the front lines. In healthcare, women outnumber men, and the global figure that I got is about 57%. And they dominate the lower salary grades and the lower hierarchies. So what is the implication of this? Women, because of their position in the health system hierarchy, they are the ones that are vulnerable to systemic changes. And one of the things that we've seen during this past 9 months is that gender inequities that are already embedded in systems may transform to gender violence. So we see this even in a country like the Philippines that is touted to be one of those with very good gender parity. We've seen that during the crisis, this quickly has turned into very deplorable conditions that has threatened not only the security of tenure of the health workers, but even their physical survival and their physical well-being. For example, here in the Philippines, there were reports that because the community who did not really understand what COVID was all about, turned away from the health workers, mostly the female ones. So some of them were kicked out of their apartments and their lodging, and were asked to look for other housing because they were afraid that they would bring the infection to the families of those that housed them when they were boarding with families, or even in the dormitories, the commercial dormitories. They were afraid of getting disinfected. There was also a case where a nurse in one of the provinces was thrown some liquid, Zonrox, Clorox, as she came home. And the transportation operators would not take health workers, especially when they were in their scrubs. The scarcity of resources, we know, have brought this into. So when there is a scramble for transport, housing, even the availability of PPEs, it's the frontliners, the rank and file, that do not have access to this. Fortunately, after a few days, it was realized that this became a problem, and nurses said they will not be going to work if that situation does not change. And then we also have to look into token recognition that does not really translate to the protection of the health workforce or to the development of their well-being. Yes, the health nurses in many countries have been called heroes during COVID, but there is a big disproportionate number of them that have died from COVID. So these heroes can be live heroes, not dead heroes. And especially for Filipino nurses around the world, we've seen this figure going up. So what are the probable solutions? The biggest and single solution that I see that we have also explored in our HRH 2030 project funded by USAID is to integrate to formal HRH systems, planning and policies, gender competence, and equity measures. They need to be built in. The health systems components definitely can take gender competence and equity policies that will improve the development, the management, and the retention of health workers. And we can see the solutions from the problems that we have observed. The failure of human resources planning and policy include a lot of areas, from the selection and screening of candidates. So there are usually urban bias, and here in the Philippines, we can see that there is also a gender bias. The males get hired first before the females. There are also failures in contractual conditions, which would ensure staff safety and well-being. In the past, our generation before us, all nurses were housed within the hospital. It was the responsibility of the health facilities to ensure that they had adequate and convenient housing. That has already been cut, and so they are left to their own arrangements. And in situations like COVID, this has become difficult. There's also a failure of the system to manage or reverse the decline in health workers' pay and conditions. At first, if there is a shortage, usually health workers' pay and conditions are high and are at parity with other professional levels. However, over time, because the biggest number and the biggest expense of most health facilities are staff expenses, salaries, compensation, benefits, they tend to cut budgets by cutting the salaries, benefits, and compensation of health workers. And a lot of these are the nurses who are perceived to be, and especially when they're single, not needing really adequate, high salaries because they can get by with very little. And so it necessitates that these women will have to make the adjustment themselves. Career structures are also problems, and migration, especially out migration from countries, also becomes a problem. So we see in the integration to formal systems the need to take into account from the beginning, when you plan, to actually look at the gender balance of proposed staffing or projected staffing. Gender is a very important major qualitative factor that has to be taken into consideration in planning. An example is here in the Philippines. We were trying to understand why men did not approach the health centers for their problems until it was too late. So for example, some of them would have early signs of diabetes or early signs of hypertension, but they would not go there. And upon discussion and inquiry, we found out that men thought that because the health staff was mostly midwives and nurses in the primary care units, that these were women's clinics and therefore could not service them. So they attempted to enter the healthcare system at a higher level, at the tertiary or secondary level, but that is difficult and expensive. And then there's also this issue that HR planning and policy has not involved stakeholders themselves in developing training and career paths. The curriculum needs to be aligned to the needs of the institutions, and especially the health worker that staff these institutions. For health workers themselves, building gender competence within their systems is important. So before they take a job, they need to check conditions of work, whether or not these work conditions are promotive of their well-being. So there are laws about nursing mothers who should be able to bring their babies to work, so that and have a nursery or a creche especially for staff children. But this is not very well implemented in many countries, including mine. So systematic attention has to be given to gender dimensions as we restructure healthcare systems to deal with universal healthcare. the needs of health workers, as well as the needs of the clientele who will make up the demand for health services in every country needs to be looked at. We can talk about this later as we go on. Also, thank you so much for your attention, and in my country, mabuhay, long live to everyone. Thank you.
Thank you so much, Professor Lorenzo. That was a comprehensive presentation outlining the broadly sort of gender and health inequalities in health, but then talking about inequalities in the human resources health profile in each country, and then the profound contradictions that we are facing the COVID-19 pandemic, and those who are, as I said earlier, and you said, heroes of the responding to the pandemic are coming last in how we treat them in terms of pay, protective environment, respect, and many other things that would enable them to respond more effectively to the pandemic and as their rights as individual citizens. So, and you gave numerous examples from the Philippines of the multiple dimensions of this. So we'll come back to some of your insights from the Philippines. I want to quickly transition to Dr. Amin, who will be talking about some key lessons in gender-based violence and how can they link up with the solutions you highlighted in your presentation. Thank you so much, Dr. Amin. Over to you.
Thank you. I don't have a PowerPoint, so I'm going to just share some of the learnings we've had from the violence against women prevention field, and then perhaps link that to how those could be applied to the human resources for health. One of the first learnings we've had in the last decade or so especially is that violence against women is preventable, and it is preventable within a reasonable period of time. In the last decade, there has been an increasing body of studies, evaluations, trials, etc., that show what works and what does not work in preventing and addressing violence against women. And the takeaway here is that we actually have to pay attention to both what works and what doesn't work. Based on all this increasing evidence, including most recently the What Works initiative that is led by the South African Medical Research Council and funded by DFID that just came out last year, is we've put together a framework called the RESPECT framework. And RESPECT, each letter of RESPECT stands for 7 strategies for preventing violence against women. And behind each strategy is a very robust and increasingly robust body of evidence of interventions. RESPECT is developed by WHO, UN Women, together with 12 other agencies, which include UN agencies, bilateral agencies, and the World Bank. And RESPECT stands for, basically, each letter stands for 7 strategies, and R of the RESPECT stands for interventions to strengthen relationship skills, which include couple counseling and healthy communication, conflict resolution skills in intimate relationships. And one example of that is the Stepping Stones intervention that was developed in Uganda and is now implemented in more than 40 countries around the world. The E for RESPECT stands for empowerment of women. And this includes combined microfinance and gender training, mentoring and safe spaces and vocational training for adolescent girls, as well as women. And one of the most sort of prominent interventions under this is called the IIIGH study, which was developed and evaluated in South Africa and is now being replicated in Tanzania as well as in Peru. And it includes other forms of gender empowerment training. The S stands for services. Services including health services, legal services, justice services, social services. And under here, we have a whole range of interventions across sectors that include women's police stations, that include psychological empowerment and psychological support for women, identification of intimate partner violence, etc. The P stands for standard, what we call standard poverty reduction efforts, including cash transfers, employment for women, inheritance and property rights, and asset rights interventions for women. And here too, we know some interventions like cash transfers work in some settings more than others. The second E for respect stands for creating enabling safe environments. So safe schools, like whole of school interventions, workplace harassment interventions, safe public spaces, safe transportation, etc. And then the C of respect stands for child and adolescent abuse prevention, which includes interventions like home visitations, parenting, sexuality education. And the T, the letter of respect stands for transforming unequal gender attitudes, norms, beliefs. And here, included in here are things like community mobilization. One example of that is SASA, which was developed in Uganda and again being replicated in many countries in sub-Saharan Africa. One of the things that we also have to pay attention to, in addition to these 7 strategies and their evidence base, is that how they are implemented is as important as what is implemented. And what we are learning from all these different increasing bodies of interventions is that one of the most important ingredients for success is the fidelity to core elements of the intervention, and that core element across the board has been challenging unequal gender and power. So the ones that work have a very strong component, an element of challenging unequal gender and power. The other core element or important factor of success is intersecting discrimination based on race, ethnicity, disability, etc., so that these interventions are targeted to the most vulnerable. Another ingredient for success is to make sure that these interventions work in tandem. So borrowing from the HIV field, the notion of combined programming, working with individual women, couples, households, and communities, and at the societal wide level. We know, for example, that there is no one magic pill or magic bullet. It is all these interventions working together that really make a difference at the population level in scaled up sense that make a difference in rates of violence. And the other important thing is that when you implement interventions that have worked in one setting and take them and transport them to another setting, it's extremely important that you pay attention to the context, because what works, for example, in South Africa may not work in the same way or to the same extent in Tanzania. And therefore, the critical element for success is to pilot, to adapt, and to carefully monitor and evaluate, even when you're replicating proven interventions. The last point I wanted to make about effective strategies for gender violence is that we need to have enabling environments in countries for these interventions to succeed. And what is an enabling environment? What we're learning is a conducive legal and policy framework where violence against women is not accepted legally and in policy, where there are leadership, the leaders at the community level, at the societal level are speaking out about that it's not acceptable, where budgets, and this is very, very important, where budgets are allocated, because unless governments put their money where their mouth is, we are not going to make a dent in population-based prevalence rates of violence. And the last thing I think is important and perhaps cannot be overstated in its emphasis, and evidence has shown this, is countries where there have been autonomous feminist women's movements, grassroots movements, have been the ones that have made the biggest change, because it's the women's rights movement that has actually made a big difference to this field. There's a very interesting study by Toon and Weldon, which shows that over 4 decades, it is actually the feminist movements that made a difference in changing laws and policies on violence against women in about 70 countries over 40 years. And that's a very, very key message to take away. Asha, just want to do a quick check. How much time do I have? Asha?
We are do you want to wrap up, provide, and then we can come back to any session.
Okay. All right.
Did you
I'll
hear
okay,
what
so
I said? The internet was able.
you may want to, if you don't mind, just put it in the chat box because you were fading in and out.
Sure. We're running over time. So
okay. All right. Let me make a few,
and then we'll come to points in the Q&A or in the discussions.
Okay. Okay. So just quickly to link this to the human resources for health field, I think the first thing I would say learning has been that, you know, similar to how the feminist movement has led violence prevention field, I think in the human resources for health, that the health response to violence against women has been led by nurses and midwives. Any innovation that has been done in this field has been actually done by nurses and midwives, largely because they are at the front line. In forensic medicine, we have a special card of nurses that are trained to respond to sexual assault called the SANEs, or sexual assault nurse examiners. So it is a very important, I mean, the health, human resources for health field, the health workforce has a critical role to play in identifying and supporting survivors of gender-based violence and in providing them an empathetic, survivor-centered response. The second point I wanted to make is that given the gendered nature of health workforce that Professor Sir Lorenzo pointed out, is that nurses and midwives themselves are experiencing high rates of violence in their own lives, whether it's in their own intimate, you know, personal relationships, in their households, in their communities, as well as in the form of sexual harassment in the workplace, which Asha, your BMJ paper referred to. And one interesting finding in some of the studies is that the nurses, for example, that report a history of past abuse or violence also seem to experience higher rates of workplace bullying and harassment. The literature on prevalence of violence against nurses and midwives and health workers writ at large is quite scarce. You know, some studies suggest as high as 25% sexual harassment faced by nurses and 37% sexual harassment faced by midwives, but this is based on a few studies. The third point to recognize from the violence against women field is that just as it affects the health of women, it affects the health of nurses and midwives, and it affects their ability to provide quality care. So in South Africa, study shows that, you know, nurses themselves hold views because of that violence against women is acceptable because they themselves have been subjected to violence, and it affects the care that they provide to their clients. And the fourth is to recognize that we are really hampered by good, robust epidemiological data on prevalence of violence against health workers. And what has made a big difference to the violence against women field in putting it on the global health and development agenda over the last 25 years is the prevalence, the multi-country study and the prevalence surveys. And I think it's time to really look at how we can gather more robust evidence on violence against the health workforce. I think, yeah, I would say way forward, we need to understand how nurses are experiencing violence in their personal and professional lives. The second is that ensuring healthcare settings have policies in place that protect health workforce against sexual harassment. And the third is recognizing that professional medical, nursing, and midwifery associations are really working towards addressing violence against women. The WHO Global Plan of Action on Health Systems Response to Violence exists with a very strong recommendation for professional associations to lead and champion this. And if you really want to build a gender responsive health workforce and a gender responsive health systems, then the violence against women and addressing that through the health systems is one very concrete and practical entry point for dealing and building much more broader set of gender issues, addressing much more broader set of gender issues in the human resources for health. And I stop here.
Thank you. Both of you have such a wealth of knowledge and experience to share. That was incredibly rich. And what I got from your presentation, Avni, is some key points is there's been over time building evidence on what works, but also what does not work. The respect framework, in some ways, I was struck by Professor Lorenzo's slide on policy solutions. There's quite a range of things that could be done, and the respect framework is a comprehensive approach to violence against women. And in that sense, I think when we're looking at advancing gender equality and health, it's not a magic bullet approach. There are a number of opportunities and they need to work in synergy with each other. And you spoke about understanding context. We have just over 15 minutes left. Answer session is open, and I wonder if we look at weave in any ask the that the question for the discussion between answered. So I wonder, looking at the questions that are coming up, whether you also sorry, I got bumped off. I don't know why. So I think one of the first questions, I'm back, was talking about whether government health systems should be mandated to report and discuss workplace harassment. In India, various state health services don't have an HR department that looks at promoting and monitoring health worker rights. I don't know what the situation is in the Philippines. Certainly when we did that BMJ article, we saw whether sexual harassment is recognized as a problem, whether there are units that are monitoring it, whether there are legal rights, varies tremendously by country. And this speaks to Avni's point of an evidence of what is the extent of the problem is key. I don't know if Professor Lorenzo would like to start in responding to that.
Yeah, thank you for that question. Well, yes, well, first of all, that is part of HRH policy and planning. All health facilities must have HR departments. I think that's one of the things that we've been trying to advocate for, even in the Asia Pacific Action Alliance for Health Human Resource Development. So once you have HR departments that are responsive to the needs of health workers and the clients that they serve, then all of these will fall into place. So for example, one of the components of HRH systems is what we know of as occupational health. Traditionally, occupational health was mainly concerned about environmental factors like, having ergonomic chairs, good lighting. But if it was integrated, if gender competence and gender issues were integrated into occupational health, then as a policy or as a subcomponent of occupational health, then there would already be standards and guidelines that would be put in there as to what is acceptable behavior of supervisors and also of underlings and peer relationships that would protect women, especially when the young nurses or the young midwives get into the facilities. They're very vulnerable to bullying, sexual advances, and unless you have a policy against sexual discrimination and all that, they will remain vulnerable. So so I think the groups that work on women's rights and feminist movements should be at the forefront of really making sure that the workplace policies include gender competence, and also these women that come in must be made aware of what the culture is within the health facilities, and that there are certain, what I saw in the question, paternalistic or tendencies or practices that are already there that may make them more vulnerable. So incorporating them into the policies and the planning and the structures for HRH management is key to protect the health workers. Thank you. Over to you.
Thank you very much, Professor Lorenzo. You've outlined, how critical it is to change, to ensure there are HR departments, but also to broaden the remit of how we think of occupational health and the rights of health workers themselves, and the importance of working with social movements and in addressing these issues. Dr. Amin, did you have some thoughts also on the extent of monitoring legislative protection in these areas?
Yeah, I think maybe just to build in on one of the questions around reporting of harassment, I definitely think that workplace harassment policies need to be in place. The issue of reporting is a bit tricky. Of course, aggregate data on reports of harassment have to be collected and reported for monitoring purposes and accountability. But I do think that, in order to encourage people who have been subjected to bullying and harassment, a conducive environment has to be created. And what do I mean by conducive environment? We know from data that most people who are subjected to sexual harassment or any form of violence never come forward. And why is that? Because the systems are very judgmental. They don't believe them. The process of reporting and getting justice and getting services is worse in some ways. We call it sort of the re-victimization, right? So what WHO's recommendation for creating a survivor-centered systemic response holds true even for addressing workplace harassment and bullying. And that is to make sure that you have trained staff who are able to support the survivors of workplace harassment, that they are able to provide empathy and non-judgmental response, that they can accompany the person who has made a complaint or is reporting sexual harassment in the workplace through the process of getting help, making sure that there's psychological and psychosocial support for them. And what is really, really important is that this should not be what we call mandatory. The choice of survivors of any form of violence to report is important, because they know themselves that they are in the best place to judge for themselves whether this is something that they can go through or not. So it is important to create that survivor-centered response, systemic response, in order to encourage more and more people in the health workplace to come and report. I'll stop here and maybe take the next question.
Sure. I think that was so important in terms of outlining not just what needs to be there legally, but the enabling environment as well, and the lack of systemic information on this, but also in your response emphasizing the importance of choice in reporting and that principle of empowering women themselves who are experiencing this. The human resources field often develops policies for health workers without their involvement as well. It can be a very top-down field. So I think those principles hold. We have 10 minutes left. We will be sharing some resources as well as contact information. I see that that's been some of the questions that have come up. I wonder, there's a question that I think there's a question to Professor Lorenzo on the extent of reforms in HRH education that includes interpersonal communication. The respect framework covers interpersonal communication, conflict management, shared decision-making. And have you seen changes to how HRH education is done to build the capacities? Because that came up in Dr. Amin's comment as well. Do we have health systems that really support health workers who are victims of violence to actually to resolve conflicts that come up in the workplace? Thank you. And then after your response, we'll move to closing statements. Thank you.
Yeah. Thank you. Very quickly, yes, there are both pre-service and in-service training opportunities to actually build in gender competence for health workers. One of the things that we have experimented on in our project in the Philippines was to put all of these information in e-learning modules that can be accessed by both pre-service and in-service trainees. And then you will see, one of the things that we fail to do in HRH training and development is follow up post-training, what happens, how they apply this, or whether or not there are barriers in the environment that do not allow them to practice, for example, gender competence. And so post-training supervision is very important, and all of these will have to be competency-based. So that's why we talk about gender competencies. So what are the standards? And if there are standards that are set for gender competency for health workers, that needs to be built into pre-service education at the senior year. We have attempted to do one such module with the ILO, but with regards to migration, but it is to help health workers know that they have the right to sign only proper and legal contracts from the recruiters. We have tried put in gender content. So looking at what are the criteria that they need to look for in the contracts that they sign so that they are not disadvantaged when they come in. So yes, e-learning provides us with very many possibilities for that. Thank you.
Thank you. You're taking us into the future now that we're all operating in a virtual environment. But I think another important thing that you said was also, you know, advancing gender equality is not a one-off activity. The follow-up, not only does the respect framework and the interventions you outlined require comprehensive multi-sectoral effort, but also follow-up to make sure those synergies are there. So once you've done the training, what happens after that? Very valuable. Let's move to closing comments. Maybe I can start with Dr. Amin and then come back to Professor Lorenzo. If there's one thing, listening into the conversation, the presentations and the questions from all the participants, if there's one thing that you think people should, that you think is critical for changing gender equality in health, particularly looking at human resources for health and the lessons from gender-based violence, what would it be that you would recommend, and what would be your magic wand? Thank you.
So I just wanted to build on the point that Professor Lorenzo made. In fact, her last point kind of fits very nicely into my takeaway message about competencies. So the WHO guidelines are very clear that all health workers must be trained to respond to gender-based violence, and the training not only should include training on clinical care, but on their specific gender attitudes and biases and beliefs. And that sort of leads to the kind of competencies we need to address gender issues writ at large. And we have a training curriculum that outlines training competencies for health workers to respond to gender-based violence. And one of the competencies is around critical reflection of gender beliefs, attitudes, and values. So this is something that the tools and resources already exist. we have been piloting this in countries, and one of the places we are piloting it is in medical colleges in Maharashtra in India, where we are teaching, the doctors and nurses are teaching the residents and medical students on responding to GBV through the health system. And also part of that competency includes gender attitudes and beliefs. And this is part of an overall effort that is led by the Center for Health and Education and Allied Themes, SEHAT in India, to build or to integrate gender into medical education curricula. And that is an important sort of takeaway message, which is to integrate both gender, including gender-based violence competencies in pre-service and in-service training, to make sure that this is there early enough in the nurses, midwifery, and medical school education curricula, that it is continued over time. As you said, Asha, one-off trainings rarely work. And that it is accompanied by supportive supervision and mentoring. In India, in our hospitals where we're working, we've actually trained the administrative cadre to be both supervisors and mentors to the residents, and that has made a huge difference because you have champions within the system, within the hospital system, to mentor the junior residents and medical students as they move through their training. So I'll stop here with that key message: integrate gender into medical education, nursing education, and midwifery education, and build competencies not only on gender, but also on how to respond to gender-based violence.
Thank you so much, Dr. Amin. I know it's hard to wrap up so much to say in such a short period of time. Professor Lorenzo, your takeaway message and your proposed magic wand.
The proposed magic wand. I think with all of these, I'd like to say that building gender competence and preventing gender-based violence in health systems and in health facilities is possible. But a lot of work has to be done in terms of really building the systems that would contain the policies and the interventions for future plans. Unless that is done, the cycle will repeat itself, and there will always be victims, and there will always be tyrants in any system. So if we do not create and build into systems, much like what we do for approaching universal health care, we use the WHO health system pillars. Within those pillars, we need to integrate gender competencies, and that will actually, and the biggest, and one of the main pillars, human health, human resources now has thankfully been identified as a separate pillar. Before, it was just under health services. We can put it into the health services pillar, but failure to integrate this into formal policies and systems will actually be a step in allowing gender-based violence to happen again and again. Thank you.
Thank you so much for both of you for sharing and for everyone's questions. We've run out of time, but I think what we will do is we will develop a blog that responds to all the questions and have a follow-up summary of this conversation of key points, because I think there's been so much shared and really valuable questions posed by the participants. My takeaway, I have 3 takeaways actually, or wands. I think we need more systematic evidence. I think the work in gender-based violence has shown the systematic surveys they have done to show the extent of the problem. We're not doing enough of that in the human resources for health field. We have anecdotal studies. We need more a systematic approach to evidence gathering. That needs to then be shown to the public light, transparency, the extent of the pay gaps, the extent of vulnerability. That transparency is critical so that we can build the political will so that action actually takes place. Those of us working in this field know the profound contradictions, but we need to bring others along to really spur action to respond, to change the situation. So thank you so much for both speakers for sharing so much of your expertise on this topic. And we look forward to working together, not only in doing a blog, responding to the questions, but perhaps a short commentary that captures some of the key insights. That would be so valuable. Thank you for your time. And thank you everyone for logging in and joining us in this first webinar series convened by UNU for the Gender and Health Hub. Stay tuned. There will be more coming up. Thanks very much. Have a good evening, afternoon, and morning, wherever you are.